to turn the recording.
Good evening and a warm welcome to all the dignitaries present here. Myself Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by National Neonatology Forum, and the topic of today's session is NNF Shine Week 3 South Zone. So let's begin today's session, for which I would like to hand over the session to Dr. Sindhu ma'am. Over to you, ma'am. Kindly proceed with your talk.
Sure. Thank you so much. Can you enable screen sharing?
Okay, ma'am. I'm doing it. Ma'am, you can do it.
Sure.
ഇഷ്ടമായില്ലേ ഞാൻ കഴിക്കാൻ പോവുക ക്ലാസ് ഉണ്ട്.
So good evening, everyone. Today we will talk about care of low birth weight baby.
Hello.
You can mute
യൂണിഫോം
yourself. Please mute yourself. If you have any queries, you can write in the chat box or you can raise your hand and we will unmute you. So the objectives of this presentation are to let the participants know how you can assess a low birth weight baby, how you can differentiate whether this low birth weight is due to prematurity or small for gestational age, and how you can manage these babies in hospital and at home. So what is a low birth weight baby? A normal weight baby weighs 2.5 kgs and above. A low birth weight baby is one where the birth weight is less than 2.5 kilograms. We can also subsequently classify based on the weight as very low birth weight when the weight is less than 1.5 kg, extremely low birth weight when the weight is less than 1 kilograms. Babies can also be classified based on their gestational age. So term gestation is 37 completed weeks to up to 42. Preterm baby is one when the gestational age is less than 37 weeks. We can subsequently classify preterm babies as late preterm, 34 to 36 weeks as late preterm, 32 to 33 weeks as moderate preterm, very preterm is 28 to 31, and extremely preterm is less than 28 weeks of gestation. Why is it important? Because even though late preterm babies can have good weight, they have a morbidity including respiratory distress, hypoglycemia, and neonatal jaundice. So each category based on their complexity of morbidity, we can classify them based on their gestational age. So why are we talking about prematurity and low birth weight today? So worldwide, if you see, the rates of prematurity is about 14 to 15%, and low birth weight babies approximately account for 14 to 18%. As opposed, India has a very high burden of low birth weight and prematurity. Our low birth weight rates are to the tune of 30%, and prematurity rates are to the tune of 18%, which is higher than the overall worldwide rates. So low birth weight and preterm babies have higher morbidity and mortality. So that is why today the first chapter, our focus is on low birth weight and prematurity. Most of these babies can be managed with very simple, cost-effective interventions. So when we talk about a low birth weight baby, which is a baby less than 2.5 kg, the low birth weight can be due to two reasons. One is prematurity, the other is small for gestational age. You can also call this as intrauterine growth restriction, but there are subtle differences which will be which we will see later. So small for gestational age is babies whose birth weight is less than 10th centile for that particular gestational age and sex. So it is a statistical definition. So when you plot the weight for gestational age, if the weight falls less than the 10th centile, you will call it as a small for gestational age baby. So look at this particular example. So this is an intergrowth growth chart, isn't it? So you have the gestational age marked in the x-axis, you have the weight. So you have this green line which stands for the average or the 50th centile. You have two more lines, which is the 10th centile line and the 90th centile line. So any baby who falls below the 10th centile line, you will label as small for gestational age. If the baby is less than 37 weeks, it's a preterm baby. Above 37 weeks, it is a term baby, but small for gestational age. So both preterm as well as term babies can be small for gestational age. Weight above the 90th centile is large for gestational age. Between 10th to 90th centile is appropriate for gestational age. So what are the risk factors for prematurity? So risk factors are a multitude. So we have tried to decrease birth asphyxia, sepsis, but prematurity, there is no specific cure because the rates of prematurity are, the risk factors are multimodal. So if there is a previous history of premature birth, mother's age less than 18 or above 35, multiple pregnancy, mother has undernutrition or obesity, either before or during pregnancy, assisted reproductive technologies, multiple miscarriages, physical trauma or injury during pregnancy, uteroplacental abnormalities, substance abuse, poor nutrition in the mother, infection, extreme stress or physical activity during pregnancy. These are some of the risk factors for prematurity. So how can we identify a preterm baby? So there are three things that you can consider. One is calculate the gestational age based upon the mother's last menstrual period, that is LMP. From that you can estimate. If you have a first trimester ultrasound, it is more accurate. So you can use the antenatal sonography, especially the first trimester ultrasound. If you don't have either of these and the baby is already delivered postnatally, you can examine the baby and you can do a systematic examination using the expanded New Ballard scoring system, where you combine both physical and neurological maturity to estimate the gestational age of a baby. So now let me ask you, what are the fallacies in estimating the gestational age using LMP? You can type in the answer. What are the fallacies when we estimate gestational age using last menstrual period? It's the first day of last menstrual period. So I'm getting a few answers here. One is recall, isn't it? They may not recall it correctly. Second is cycles are irregular. So cycles can be irregular. Fine. So these are the issues, and sometimes they may have been on some oral contraceptives and later became pregnant. So they may not reliably recall their last menstrual period. So the accuracy is limited when we estimate the gestational age based on the last menstrual period. So what is the second best option as well as the gold standard, which is considered the gold standard, is doing the crown lump rump measurement in the first trimester ultrasound. So the ultrasound has to be taken before in the first trimester, between the 11th to the 13th week, it has to be taken. So that's considered the gold standard. Even then, the estimated gestational age would be plus or minus 7 days or a week. So if there is no first trimester ultrasound and the mother does the second or the third trimester ultrasound and you estimate gestational age, the discrepancy can be as high as 2 or 3 weeks. So if you don't have either of these, the final thing that you can do is look at the baby after birth and try to estimate. So again here the discrepancy can be as high as plus minus 2 weeks. So how can we, now let's look at some of the physical parameters which can be used for identification of the preterm baby. So this is comparison between the preterm and term baby. So one is we can look at the skin. In the preterm baby, the skin can be very thin, transparent, visible veins can be seen. Term baby, it will be more thicker as well as keratinized. It may be more pigmented also, especially when you look at the breastbud and the scrotum or the labia, it may be more pigmented. Hair in preterm baby, you will have an abundant growth of lanugo hair, especially on the back. Whereas in the term baby, the hair, especially where it rubs against the surfaces, especially between the scapular blade, there would be thinning of the hair, thinning of the lanugo hair. When you look at the scalp hair, it is fuzzy, woolly in preterm, whereas it is more thick and shiny in term babies. If you look at the ear cartilage, it may not be that much cartilaginized in preterm baby. So there is less of a recoil and the ears can be very much folded. Whereas in term babies, the ears have an instant recoil. Breast nodule less than 5 millimeter, 5 or more millimeter. You have to palpate the breastbud between the 2 fingers and palpate it and measure it. Sole creases, the soles may not have any crease at all in extreme preterm babies. It may have creases up to the anterior 2/3 in preterm, and in term babies, you can have creases up to the 2/3 of the sole. Then we can look at the genitalia. In males, the rugosity is less, the scrotum is less pigmented, testes may not be fully descended into the scrotum. Females, the labia are widely separated. The clitoris may become more prominent. In term babies, rugosity is well formed, testis is descended, more pigmented, pendular scrotum. In females, the labia majora covers the minora and the clitoris very well. We'll have a look at a few pictures to understand more. So this is a preterm baby. This preterm baby is also small for gestational age. So how do we know that this is a preterm baby? Look at the breastbud. They are very thin. How is the skin? Skin is also very thin, very pink. If we look closer, we may see the visible veins. Okay, so ears can also be examined. And this baby I am seeing is small for gestational age because when you look at the facial features, there is a triangular faces, loose skin folds also. This is a term baby. Look at the hair. It is very thick, shiny. Look at the ear cartilages. Look at the breastbud and look at the genitalia. The labia majora closes the minora. Clitoris is not visible. And sole creases also we can look at. So this is again a preterm baby. Look at the skin. It is very thin, shiny and pink. This is lot of lanugo hair on the back, and whatever the white substance you are seeing is vernix. You can also look at the hair in this baby. It is very thin, fuzzy, woolly hair. This is an image of an extremely preterm baby. Look at the gelatinous skin, very thin skin, and you can see the visible veins. The breast bud is imperceptible here. Look at the ear cartilage. Here, it doesn't seem to have any cartilage at all. It is yet to be cartilage has to form it. If you look at the eyes are eyelids are fused. Look at the sole crease, there is no sole crease at all. When you don't have any sole crease, you can very well measure the length of the foot. That will give you a clue. Look at the scrotum here. It is not at all. There is no rugosity, no pigmentation, and testes are not yet descended. So this is an image of an extreme preterm baby. This is a moderately preterm baby. Look at the hair. It is very fuzzy. This is the typical woolly hair. Some amount of rugosity in the scrotum, but yet to be pigmented. The testes are descending here. Look at the breastbone. It's somewhat more developed compared to the previous picture. Look at the sole crease. Some sole creases are present in the anterior foot. So you have the new Ballard scoring system where you can mark these features. Finally, you get a score. From this score, you can also derive the gestational age. This is an example of a term baby. Look at the ear cartilage, how formed it is. It has a very good shape. Look at the breastbone. It is about 1 millimeter in size. Look at the genitals. It is pigmented. The minora is not visible. Labia majora completely covers it. So a look at the baby can help you differentiate whether this could be a preterm baby or a term baby. The neurological maturation will also help us. For example, in this preterm baby, this is a scarf sign. When you take the arm, the elbow crosses the midline here. So this is an example of the tonicity. So this is a passive tone estimation. The tone is more in a term baby. The elbow does not cross the midline in this scarf sign, whereas it crosses in a preterm baby. So this will also give you a clue. You can also measure the popliteal angle here. Popliteal angle in a term baby, this is less than 90 degrees. This is approximately 60 degrees here, whereas in a preterm baby, this is closer to 90 degrees. So you can use the popliteal angle, heel to ear, the scarf sign, and the wrist angle to try and figure out whether this baby could be preterm or term baby. So the new Ballard scoring has a couple of physical parameters and neurological parameters, and a combination of them is used to estimate the gestational age. So what are the problems of a low birth weight baby? So starting from low birth weight per se increases the risk of mortality in any unit. So why the mortality can be increased? These low birth weight babies have a higher risk of asphyxia because the low birth weight per se can be either due to prematurity or the intrauterine growth restriction. So preterm babies have higher risk of asphyxia. Similarly, babies who are growth restricted in utero cannot tolerate the process of labor because of uteroplacental insufficiency. So they are oxygen deprived in utero. So the process of labor can have a higher stress on them. So they are at higher risk of asphyxia. They have less storage of glycogen and fat. They have very thin skin. They have less subcutaneous fat. So they are prone to hypothermia. They are prone to hypoglycemia. Because of their poor maturity, they may have feeding issues. Surfactant can also be deficient in preterm babies, as well as term IUGR babies are at higher risk for meconium aspiration. So both of them are at higher risk for respiratory distress. They have metabolic problems like hypoglycemia, hypocalcemia, electrolyte abnormalities. They have a higher risk of sepsis. Jaundice is higher risk, both in preterm babies because the liver is still immature in preterm babies, and even lower levels of bilirubin can cross a blood-brain barrier and can result in major problems. Small for gestational age babies are at higher risk for polycythemia, which will place them at higher risk for neonatal jaundice. So they are at overall higher risk for brain injury apnea of prematurity, anemia of prematurity, retinopathy of prematurity, higher hearing loss. Hearing loss higher because of, not only because of prematurity, but because of the associated morbidity. Morbidity due to sepsis, receipt of antibiotics, nephrotoxic medications. So overall, their long-term neurodevelopment is affected, resulting in cerebral palsy, impaired cognitive behavioral skills, psychosocial issues, and later chronic problems. So this is an example of and small for gestational age baby. Previously, I was telling you about SGA and IUGA. What is the difference between these? SGA is a statistical definition. Any baby who plots less than 10th centile will be labeled as small for gestational age. However, you can have a subset of babies who are in the appropriate for gestational age group. So they may be plotting just above the 10th centile, somewhere between 15th or 20th centile. But when you look at these babies, they have characteristic features of triangular faces, loose skin folds, groin creases will be higher, very thin subcutaneous fat. So these babies are called morphological intrauterine growth restricted babies. So these babies have low fat glycogen stores. They are higher risk of hypoglycemia, hypothermia. They are at higher risk for fetal distress, asphyxia, polycythemia, and meconium aspiration syndrome. So even though they may not be preterm, term IUGR babies are also at higher risk for these problems. So any queries until here, you can post it in the chat box now before we move on further with management of low birth weight babies. Any questions regarding gestational age estimation? So we need not exactly measure the angles. If you look at the expanded Newballard scoring sheet, these need not be, you need not remember them by heart. You need to have the expanded Newballard scoring sheet in hand, examine the baby and plot then and there. So for example, you would get an idea about how much is the angle between when you flex the hip against the body and extend the knee. So is it 90 degree? Is it goes beyond 90 degrees or is it less than 90 degrees? Based on that, there are images given there. You will circle them. Then finally calculate the scores. From there, you can calculate the gestational age. So this is available. You need not remember by heart to measure the various angles. Okay. So now we will move on further with the management of low birth weight babies. So where should low birth weight babies be delivered? So when there is a risk of prematurity or mother has a baby with intrauterine growth restriction, it is better to deliver these babies in institutions where there is also facility to manage the low birth weight baby. So preferably an intrauterine transfer to an institution is preferred. So where should we manage? Should we admit all low birth weight babies in the NICU? So if the weight is above 1.8 kilograms and the baby is above 34 weeks, the baby can be roomed in with the mother after initial resuscitation. If the weight is less than 1.8 kg or less than 34 weeks, the babies have to be cared in the Special Newborn Care Unit or the SNCU. So management involves thermoregulation. That's the most important thing. So thermoregulation is you should remember the warm chain, 10 interlinked management principles, which will keep the baby warm from birth until discharge and at home. So at home, the babies need to be nursed close to the mother, rooming in, bedding in. Keep the room warm. Then babies have to be clothed well. They need to have 2 or 3 layers of cloth. Cover the head, the hands, and the feet with mittens. Okay, so having 2 or 3 layers traps in a layer of air and acts as an insulator. So a blanket to cover the mother and baby. Kangaroo mother care is a very simple technique that has to be done for all preterm as well as low birth weight babies, because kangaroo care has numerous benefits. First and foremost, it decreases neonatal mortality under latest follow-up. It decreases the risk of late onset sepsis, helps in thermoregulation, improves the bonding, improves the blood sugar level in the babies, especially skin to skin care carried immediately after birth. So these babies have better growth and anthropometric parameters, not only after in the immediate postnatal period, but also in follow-up at 6 months and 1 year. So kangaroo care has numerous benefits for all low birth weight and preterm babies. Kangaroo care is advised. Okay. So in the hospital, especially if you are admitting these babies to a special care unit, they have to be, thermoregulation has to be maintained under the radiant warmer or an incubator. So here you can see a low birth weight baby who is appropriately clothed with mittens. So educating the parents is very important so that on follow-up also they maintain the thermoregulation. Second is fluids and nutrition. So what is the type of food or nutrition that has to be given to the baby? So because preterm babies have immaturity in feeding, so based on the birth weight or the gestational age, we can determine whether these babies need intravenous fluids or gavage feeding or katori spoon feeding or palade feeding and breastfeeding. So more mature the babies are, they can be directly put to breast. So if the baby is more than 1.8 kg, more than 34 weeks, remember these are the babies whom we said can be directly roomed in with the mother. So we can directly start them on breastfeeding. If there is any difficulty in breastfeeding, then they can be fed by palade or katori spoon. So babies in the intermediate category, 1.2 to 1.8 kg, 30 to 34 weeks. Initially, we will try the palade or katori spoon. If they are unable to swallow or tolerate, then we will put the gavage or the orogastric feeds and start them on orogastric feeding. If the baby is less than 30 weeks or less than 1.2 kg, then based on the initial stability, we can determine. If they are sick, they have respiratory distress, then we can start them on IV fluids while simultaneously starting them on minimal enteral nutrition. So if the baby is stable, no respiratory distress and can tolerate full enteral feeds, we can start 60 to 80 ml per kg full orogastric tubes to give. So over a period of time, we can start them on katori spoon or the palade feeds and slowly transition them to breastfeeding. So the initial mode of feeding, whether IV fluids or gavage feeds, palade feeds or breastfeeding, will depend upon the weight and the gestational age of the baby. So how much fluid to give? So we have to give 60 to 80 ml per kg. So you will learn more about the exact volume. You will learn the exact volume. You will learn the exact volume of the feeds in the nutrition chapter. So on the first day, the fluid requirements range from 60 to 80 ml per kg. The initial increment can be 15 to 20 ml per kg until you reach full feeds of 150 ml per kg. So adequacy of fluids is indicated by the weight gain pattern. Remember that in the first few days, there would be weight loss. Each day, you will expect around 2 to 3% of weight loss until a weight loss of maximum 10 to 14% is reached in preterm babies. Preterm babies regain their birth weight by around the 14th day, by around the second week. Okay. So birth weight is regained by the 14th week. After that, they will start gaining weight, and this can be to the tune of 15 to 20 grams per kg per day. So this is the target that we expect. They should regain. After regaining birth weight, the increment in weight gain every day has to be 15 to 20 grams per kg per day. So exclusive milk feeding, mother's milk feeding is the ideal goal that each one of us would desire. So in case breast milk, mother's own milk is not available, then the next best option would be pasteurized donor human milk. If that too is not available, the third option is the appropriate formula feed. So what other than milk, what other nutritional supplements do these babies need? So all babies should receive vitamin K at birth. The dose for less than 1 kg baby is 0.5 milligram, above 1 kg, 1 milligram. So this has to be given intramuscularly to all infants at birth. Vitamin D supplements have to be started. The dose is 400 to 1000 international unit. It is started once the baby is on feeds of at least 100 ml per kg per day feeds. Iron supplement is indicated for all low birth weight babies. So the dose is 2 to 4 milligram per kg per day. It is started from 2 weeks of life after the baby is on full feeds and at least by 2 weeks of life. Multivitamin supplements along with zinc. So multivitamin drops 1 ml per day again started when the baby is on full feeds of 100 ml per kg per day and it's given till 6 months. Iron supplements are continued till 1 year. Vitamin D supplements are also given till 1 year. Calcium and phosphorus supplements are given to preterm babies. Calcium dose is 120 to 140 milligram per kg per day. Phosphorus 60 to 90 milligram per kg per day. So calcium, phosphorus, host of syrups are available, which can be started. So we again start when the babies are 100 ml per kg per day and it is continued till 40 weeks or the baby reaches 2 kg, whichever is later. So discharge planning, when can we discharge low birth weight babies or preterm babies from hospital? So first, all medical issues, they have to be treated before discharge is planned. Second, the weight gain should be adequate. So baby should put on weight for at least 3 consecutive days. The mother should be confident in taking care of the baby, feeding the baby either directly at breast or by paladine. Nutritional supplements should be taught. The parents have to be educated when these supplements have to be given, at what frequency, how long to continue. Immunization has to be complete. So all preterm low birth weight babies, vaccination is as per the postnatal age and not as per the corrected age. So vaccination, birth vaccinations have to be complete. And all danger signs should be taught to the mother. Mother should be trained in doing kangaroo mother care. So what are the danger signs that they need to know? So they need to bring the babies to hospital if there is feeding difficulty, lethargy, fast breathing or respiratory distress, hypothermia or fever, or whenever the mother feels that the baby is unwell or sick, they need to bring the baby. So all low birth weight preterm babies, there has to be a follow-up schedule. Generally, after we discharge, we call them within the first 2 weeks to assess how the nutrition is going on, whether the babies are gaining weight, and the subsequent follow-up is coupled with the immunization visits. So growth monitoring is very, very important. We have to plot these babies on any growth chart. So generally, front-end growth chart, intergrowth growth chart can be used because they can be used at birth and subsequently during the follow-up also, we can plot these weight. So serial growth monitoring allows early identification of growth faltering. And after 40 weeks, the front-end growth chart merges with the WHO growth charts from 40 weeks corrected age. So growth monitoring is very important. So then we also need to plan screening for these babies. So all babies who are less than 34 weeks, less than 2 kilograms, or who have a complicated NICU course or who have received oxygen should be screened for retinopathy of prematurity. Hearing screen is mandatory and it is universal for all babies. Whether it is preterm or term, the hearing screen is mandatory. Ultrasound scan is for specific babies less than 32 weeks, less than 1.5 kg, or who have a turbulent postnatal course. So all these screening should be done at appropriate time for prevention of blindness, hearing disability, and intracranial hemorrhage. So during follow-up, other than growth, we have to assess the feeding status, whether they have transitioned to direct breastfeeding, how is the breastfeeding adequacy, are they growing appropriate weight, are they growing in length as well as in head circumference. So growth monitoring, feeding assessment, nutritional supplements, whether they need to be continued, how long they need to be given, the subsequent immunization, as well as systemic examination has to be done during follow-up. So how can we prevent premature births? It's very difficult, but we can have certain things to decrease the morbidity in the preterm babies. So one is antenatal steroids given to mothers who are between 24 to 34 weeks gestation and are at risk of preterm birth. These are mothers who have either spontaneous onset of preterm labor, premature rupture of membranes, antepartum hemorrhage, or who have preeclampsia or pregnancy-induced hypertension, or some either for maternal or fetal indication, a preterm delivery is being planned. So between 24 to 34 weeks of gestation plus risk of preterm birth, these mothers can be offered antenatal steroids. It can be either dexamethasone or betamethasone. Magnesium sulfate given to mothers below 31 weeks of gestation acts through certain mechanisms by which it can offer neuroprotection. So these preterm babies are at lesser risk who have received magnesium sulfate are at lesser risk for neurodevelopmental impairment compared to those who have not received antenatal magnesium sulfate for neuroprotection. So this is for neuroprotection. So these are some patients that can decrease morbidity in premature birth. So together we can reduce the morbidity as well as mortality in preterm and low birth weight babies. So now we will open up the presentation for your queries and we can discuss if there are any doubts that you have during this presentation. You can also put it in the chat box. So human milk fortifier is given for babies. First, we have to optimize the breast milk or the mother's own milk. So if you approach full feeds 150 to 180 ml per kg per day and growth is inadequate, especially for babies less than 32 weeks, less than 1.5 kg, human milk fortifier is added. It provides additional calories, additional proteins, calcium, as well as phosphorus for these preterm babies. Generally started when the milk feeds approach a volume of 100 ml per kg per day, and we add 1 gram of human milk fortifier to 25 ml of human milk. And the human milk fortifier is continued until the babies approach 2 kilograms or 40 weeks post-menstrual age, whichever is earlier. So till then, you can continue. MCT oil is not generally given because MCT oil is a monocomponent fortifier. Monocomponent is it provides only fat, whereas human milk fortifier is a multi-component fortifier. As I said, it offers calories, proteins, calcium, phosphorus, vitamin D, and some other vitamins. So it is a multi-component fortifier. Our target is 15 to 20 grams per kilogram per day. That is the weight gain. So based on how the babies are growing, you can adjust the fortification and continue. So despite full enteral feeds and fortification, if babies are not gaining adequate weight, then you have to think about other causes. For example, there can be persistent hypothermia or cold stress. Babies can lose sodium. So hyponatremia can also prevent adequate weight gain. The babies can have some underlying sepsis or urinary tract infection. So all these things need to be corrected to optimize growth. So preterm vaccination. So what are the birth vaccinations? BCG, oral polio, and hepatitis B. So all the three have to be given before the baby is discharged from the hospital. Suppose the baby is discharged by 34 weeks and baby weighs only 1.6 or 1.8 kilogram. So BCG, oral polio have to be given. Hepatitis B can also be given, but it is not counted as a vaccination, it is a zero dose. Okay. So because babies will receive 6th, 10th and 14th week vaccination, which includes hepatitis B, the baby is considered to be adequately protected against the hepatitis B. So the birth dose of hepatitis B is considered a zero dose. So sometimes not giving the hepatitis B, assuming that it will generate less immunogenicity, may result in missed dose of the vaccination. So preterm babies, it is only the chronological age. So at 6 weeks, 10 weeks and 14 weeks, they should get the whatever the routine immunization, which is for this term babies. Okay. So ma'am, do we need to aspirate NG tube for neonatal sepsis babies? For any baby who is on orogastric tube feeding, do not aspirate the NG tube prior to each feed. With routine aspiration, you will get some amount of aspirate and it may lead to interruptions in feeding and mislabeling as feed intolerance. So you should not at all aspirate. When should you aspirate? If there is abdominal distension, the abdominal girth increases more than 2 centimeters. There is altered aspirate coming out through the OG tube, like bilious aspirate, blood-stained aspirate, then only you need to aspirate the orogastric tube. Otherwise, routine aspiration is not recommended. So do we need to wait for baby to reach 2 kg for giving vaccination? Not necessary. If the baby is discharged at 1.8 kg, please give BCG, oral polio as well as hepatitis B. This hepatitis B is a zero dose. It is not counted in the schedule. Anyway, baby will receive the vaccination at 6, 10, 14 weeks. there is no need to burp the baby after giving orogastric tube feeding. However, having the head slightly elevated at 15 degrees would help the babies. Any other questions?
To NG or OG?
See, NG neonates are obligate nose breathers. So, orogastric tube is currently commonly practiced. If we put NG tube, the nose may be obstructed. So babies will not be vaccinated when they are inside the NICU. The birth vaccination is not given. So less than 1 kg baby would not be discharged from the SNCU. So they have to be given the birth vaccines only prior to their discharge. How much time NG tube should be kept closed after a feed? After a feed, at least for an hour, NG tube has to be kept closed. After that, it can be kept open. This is especially important for babies who are on non-invasive respiratory support. For example, HFNC, CPAP. So some babies still vomit even when they are on OG feeds. They may vomit because their gastric capacity is less and there can be some amount of gastric esophageal reflux. So some amount of vomiting can be accepted even when they are on OG feeds. So if the vomiting amount is more than 50% of whatever you have given, then you will have to look for feeding. If the baby is on antibiotics, is it contraindicated for vaccinating the baby? So baby is unwell. That is why the baby is on antibiotics, right? And that baby, you have to treat the infection first before vaccinating the baby. How do we increase feeds for a low birth weight or a preterm baby? The amount of increment. So if the baby is on Paladai feeds, then we say that the baby can take ad lib demand feeds. Okay, ad lib demand feeds means even whenever the baby demands, the baby can be given feeds with a minimum feed volume. For example, if the baby is 2 days old and the baby is 2 kilograms, 34 weeker, 2 kilograms, 34 weeker. So the estimated the volume that you can chart is 80 ml per kg per day. So whatever 80 into 2, 160. So that can be given in every 3 hourly feed or 2 hourly feed. So you will give a minimum volume, but if the baby takes more, you can give more. If the baby is having orogastric tube, then you would write the baby would take 15 ml every 2 hourly or 3 hourly. So every day the increment can be 15 to 20 ml per kg per day until you reach 150 ml per kg per day. Routine proton pump inhibitor or Rantac in term or not is contraindicated. You should not use any proton pump because it will neutralize the gastric acidity. Gastric acidity is important to neutralize the bacteria and prevent infection. Routine use of PPI can increase the risk of late onset sepsis. Can we give syrups through NG or OG? Yes, you can give the multivitamins, vitamin D, iron, as well as the zinc multivitamin supplements can be given through orogastric tube. What is the minimum weight to give vaccination? There is no absolute weight criteria for vaccinations. Prior to discharge, birth vaccinations have to be complete. In follow-up of preterm babies, if they missed 6, 10, 14 weeks vaccination, if they are coming at 5 months, then you have to give the 6th week vaccination at 5 months. See, for preterm babies, what is the difference between breast milk of preterm baby and term baby? Mothers who have delivered preterm babies will have milk which has higher in protein content. But even then, after 2 weeks or so, it will be similar to a term milk. If you are giving pasteurized donor human milk, all the milk will be pooled. Both preterm and term milk will be pooled. So because it is human milk, it is digested very well. What are the causes of feed intolerance and vomiting other than NEC? Gastric reflux is a common cause of vomiting, not a cause of feed intolerance. Feed intolerance, hypothermia, sepsis, malformations in the gastrointestinal tract, electrolyte imbalance, they are causes of feed intolerance. How do you treat? You have to keep the baby NPO, give gut rest, investigate what is the cause of feed intolerance. Any other questions? GER can result in vomiting and reflex, vomiting and a reflex of regurgitation of milk, okay, or milk spit-ups. It will not result in aspiration unless there are other respiratory issues when the baby aspirates the milk. So not all GER will lead to aspiration. Okay, so today you will all go and read the FBNC manual on the care of low birth weight babies. Okay. How to start feeds for a preterm such as 30-weeker. When to switch from IV fluids to tube or trophic feeds. So a 30-weeker, minimal respiratory distress, otherwise stable, no shock, no asphyxia. Go ahead and day 1 and start full enteral feeds, 60 ml. So 30-weeker may be less than 1.5 kg. So you will start 80 ml per kg, mother's own milk or pasteurized donor human milk, 80 ml per kg per day, and you can divide it into 12 feeds. If this baby is tachypnic, respiratory rate above 80 or perfusion is a problem, or the baby had asphyxia at birth, you will start the baby on IV fluids. However, as early as possible, you can start the baby on some enteral feeds, which you call it as trophic feeds or minimal enteral nutrition. The volume of minimal enteral nutrition varies somewhere between 20 or 30 ml per kg per day. Then every day, 20 to 30 ml per kg, you will increase the baby, increase the feeds. As soon as feeds reach 100 ml per kg per day, stop the IV fluids and the baby can be on full enteral nutrition. For the other baby whom you started 80 ml per kg full feeds, every day you will increase 20 ml per kg until you reach 150 ml per kg per day. Domperidone is not recommended for feed intolerance. Rantac is contraindicated. That is correct. Fine. I think you will read most of these things in detail, including kangaroo mother care, nutrition, and neonatal sepsis in the subsequent sessions. So I think Rupsa. Rupsa.
Yes, ma'am.
I think we have done with the session.
Okay, ma'am. Thank you so much, everyone, for extending us the opportunity to host the session. So with all your permission, I would like to conclude the session over here and looking forward to host you again. Thank you so much, ma'am. Thank you so much, everyone, and good night.
Thank you, everyone.
You may leave the room.
Thank you, ma'am.